Hello, I'm Sylvio Burcescu here from Mensana Center. We are going to talk about the CPT Codes 2013 edition. I am not an expert in CPT codes, but I do believe that I have a pretty good understanding of this new system. Let's start by getting out of the way the simple stuff. And what does it mean, the simple stuff? The initial evaluation is simple. The initial evaluation in the past was 90801 and 90802. You can forget about these two codes. They are completely replaced by 90791 and 90792. What's the difference? This one is for social workers and psychologists, and this one here is for psychiatrists and nurse practitioners. That means this one here has so-called medical services. And what does it mean, medical services? Medication, usually, medication related, and all sorts of other medical services. Another simple stuff is the therapy codes. So the therapy codes, in the past, there used to be 30 minutes for 90804 or 05 if they were with medical management. 45 minutes it would be 90806 if it's pure therapy, or 07 if it's psychotherapy and medication management, and 60 minutes 90808 or 09 respectively with medication management. So these are gone. Now the new therapy codes depend on whether they are a standalone. That means there's no other service built, or they are an add-on. And they are usually an add-on to the evaluation management code, which we are going to discuss in a very great detail a little later down the road. So the standalone procedures for psychotherapy are 90832, 90834, and 90837. You might ask where did the 90833 disappeared? Well, it's apparently an add-on code for the equivalent of 90832. And again, these are 30 minutes, 45 minutes, and 60 minutes psychotherapy. So it's a 3 here. So if you add on a psychotherapy code to an evaluation management, even if it's 30 minutes, you do not call it 90832, but you call it 90833. The same here, it's a 45 minutes. You do not call it the 90834, which is a standalone psychotherapy code, but you call it 90836. And here, if it's a standalone, you call it 90837. If it's an add-on, you call it 90838. Now, a very important footnote. As you see, the time is continuous. You cannot really get it right on the mark for 90832 at 30 minutes or 90834 at 45 minutes. And therefore, the the CPT code is very clear in this respect. These are, if you cut this interval in half, and this interval in half again, and this interval you do it again in half, the 30 minutes you call a visit as having lasted for 30 minutes if it's anywhere between halfway between 0 and 230, and up to halfway between 30 and 45. In fact, to be more precise, these middles are considered 16 minutes, 38 minutes, and 52 minutes. So practically a visit is called as called or noted that it lasted for 30 minutes if it's anywhere between 16 minutes to 38 minutes. And if it's between 38 minutes to 52 minutes, then you call it a 45 minutes visit, and you code accordingly. Now we have two more things. The group therapy code also changed, and now it's called 90853. And there is a new code, crisis visit. So the crisis visit is very useful because there are often people who come without an appointment. They walk in because of some kind of crisis, and all you have to do is to document the crisis visit the same as you used to. And by the way, all these codes up to this point, they do not involve any changes in documentation in the way you document the visit. So crisis visit is no exception. You document it the way you always did, and you name it 90839 if it's up to 60 minutes. So above 60 minutes, there's another code for that, but I'm not going to get into that level of detail. So now we are going into the complicated stuff. So these are the evaluation and management codes proper, which for our limited purposes are going to be 99211 up to 99215. From the beginning, as I said before, we're going to get out of the way the simple stuff. 99211, you can forget about it. Why? Because Medicare pays for about $4 or $5. The other insurances do not pay anything. Is more of a cost to document and bill this visit than not to do it at all. But of course, sometimes you need to document any kind of additional things, like patient coming to the front desk and wanting a refill of medication until the next visit. No face-to-face meeting. That's a 99211. But again, it's good to make a note, not bother to bill it, because the effort is costing you more than what you get for it, and in many situations, 90% of the situations, is going to be zero payment. So let's see, evaluation and management code, and again we start with the simple stuff. There are two ways of documenting an evaluation management code: based on time and based on an itemized note. So that's how you document, either the time or itemized. Now if you use time for a 1-1, you don't need any minutes to spend on the patient. That means you don't even have to see the patient. For a 99212, you need to spend in front of the patient 5 minutes on it. These are guiding times, are not absolute times. If you want to document 99213 by the time level, you have to spend 10 minutes. If you want to document a 99214, then you need 25 minutes face-to-face with the patient. And if you want to document a 99215, you need a 40 minutes face-to-face visit. And I didn't see anywhere specified, but I think that the same is valid for these visits as well. Correct me if I am wrong, whoever knows better. That means everything that goes between 0 and 5 up to the middle of this interval, 5 to 10, is considered a 5 minutes visit, and so on. So now you can use this simple way of documenting an evaluation and management visit. Simple, I mean that there are not much requirements when it comes to what do you actually document. You just put in there, I spent face-to-face with the patient so and so minutes, like 5 or 10 or 25 minutes. And you add more than 50% of the time it was spent on counseling. So you have to be cautious. Counseling is different than psychotherapy. And what does it mean, counseling? And it's saying anything related to explaining the diagnosis, explaining the prognosis, explaining medication side effects, explaining the importance of compliance, for example. All of this is counseling. Everything to do with medication is counseling. Of course, no social worker or psychologist can bill E&M codes, because by definition they involve medication. Okay, so this is the simple way, shortcut. You go to this to these codes by writing few sentences to document that you spent either 5 or 10 or 25 minutes in front of the patient, and you used more than 50% of the time to counsel the patient regarding specifically one of these areas. So now let's go to the complicated part, and I'm going to start with which is the most important part. So the itemized, well, if you want to itemize a note, then you have to itemize the following parts. Medication decision, you have to document a medical decision, not medication decisions, but medical decision. Then you have to document the examination, and the history. So what does that mean? The visit will consist in you taking a medical decision, and you just describe the medical decision that you took according to some rules. Then you do an examination. Now in psychiatry is a little different than in others, because examination may involve just talking with the patient. So I'll explain to you in more in detail. And then history, that means you ask the patient what has been going on, what is the reason why they come to their visit. And again, it's a ritual that has to go according to certain rules. So these are the three factors of the itemized E&M note: medical decision, examination, history. In fact, it doesn't appear like this in the note. In the note, it has to appear first history, then examination, then medical decision. And SOAP does not quite exist anymore if you want to document specifically for this purpose. Or you can say that the subjective part, you can fit it in the subjective part, you put in the history. In the objective part, you put the examination. In the assessment, you put the medical decision. And finally, the plan remains the plan. There's nothing to replace that. So if you want to still use the SOAP format. Now, let's go one by one. First, medical decision. Medical decision is measured in complexity. Complexity. And the complexity can be straightforward, can be low, can be moderate, or can be high complexity. And this depends on factors, depending on factors. And what are these factors? Risk, presenting problem, and data. What does it mean? The medical decision is more complex when there is a higher risk, when the presenting problem is more complicated, and when the data that you need to evaluate is higher in volume. So now let's see. The risk is described as minimal, moderate, sorry, here there's not moderate, but it's low, and finally moderate and high. The presenting problem is measured in points, and the ranking here according to the number of points. 0 to 1 is the first ranking, 2 is the second ranking, 3 points is the third ranking, and 4 points is the fourth ranking. The data also is ranked by points, and the same as presenting problem. 0.1 is the first level, the second level is 2 points, the third level is 3 points, and finally the fourth level is 4 points. Now let's see the risk first. What does it mean, minimal risk? Minimal risk means either a minor problem and no medication, so minor problem and zero medication, that's minimal. Low is when you have two minor problems, or one chronic but stable problem, or you have OTC medication, over-the-counter medication. What does it mean, a risk that is moderate? A risk that is moderate means one chronic problem with acute exacerbation, or two chronic problems, but stable problems, or prescription medication. So again, any of these conditions that if you are met, you call the risk of that medical decision as moderate. Now the high, what does it mean high? When you have one acute or chronic with severe exacerbation, that means life-threatening or threat of bodily harm. Or you have a prescription medication which is complicated. And what does it mean? Clozaril is a prototypical prescription medication that is complicated, that needs continuous monitoring. And Depakote would fit the same description. Lithium, definitely. So whenever you are dealing with a patient who is on either prescription medication that is actively managed, so it's not enough to be on prescription medication, but if you prove in your note that you actively manage that prescription medication, then you call the risk moderate. If you have a patient on a medication that needs continuous monitoring, then the risk is high. So you either look at the problem, presenting problem, or at the management, and you decide the level of risk. Now the presenting problem is also ranked according to the number of points that you get for different variety of presenting problems. For example, if you have one minor problem or one chronic but stable, so one minor or one chronic but stable, you get 1 point in terms of presenting problem. If you have two chronic problems or two chronic problems or one chronic problem that is getting worse, you get 2 points. And if you have a new problem, you get 3 points. And if you have a new problem that needs further workup, then you get 4 points. So this one here maxes out at 2 points. So maximum is 2 points. This one here maxes out at 1, the new problem. That means if you have one minor problem or one chronic stable problem, you get 1 point. If you have 2 minor problems or 2 chronic stable problems, you get 2 points. But if you have 10,000 minor problems and 10,000 chronic but stable problems, you still get 2 points. The same with this new problem. The new problem is can be only considered 1. If it's 1 or if it's 10,000, is the same. You get only 3 points. And the new problem that needs further workup is you get 4 points for it, and for some reason that is not kept at anything. But obviously there is no reason for you to document a ton of new problems that need further workup, because you do not get beyond a risk score of 4. Now the data points. The data points are the most difficult to attain. So, for example, you get 1 point for looking at lab results. You get 1 point for looking at radiology exams, actually interpreting them, or an EKG, for example, actually interpreting the EKG yourself, not just reading the interpretation. So these are all 1 points. If you take information from collaterals, that means if you interview parents, for example, you get 2 points. And if you visualize a test, for example, if you look at a specimen, urine toxicology specimen, you get also 2 data points. But anyway, in psychiatry, it's usually very difficult to go very high on these data points. But fortunately, the medical decision is decided as follows: 2 out of 3 of these items, risk, presenting problem, and data points, must meet or exceed the level of medical decision complexity that you want to claim. That means if you have a medical decision that you claim is of moderate complexity, then you have to have a risk that is moderate, and a presenting problem that is at least at level 3, the least of 3 points, in order to claim that you are dealing with a medical decision of moderate intensity. So you see, 2 out of 3 must meet or exceed. Of course, for example, you have a risk which is high, a presenting problem that is ranked as a 3, and let's say data points 2, you still can claim only this one here, because 2 out of 3, risk is high, it's higher, exceeds the level of moderate, but the presenting problem is only ranks as a 3. That means that you can claim only the level of moderate. So this is a medical decision, and the medical decision is important because it dictates pretty much the CPT code that you want to use. You cannot use a CPT code that involves a lot of work without justifying it through medical necessity. That means without having a medical decision that is complicated, towards the complicated side. Now, let's look at the examination. The examination is measured in bullets, and it can be of 4 varieties: problem-focused, extended problem-focused, detailed, and comprehensive. What does it mean, problem-focused? When you have only 1 bullet. Extended problem-focused when you've had at least 2 bullets. And it becomes detailed if you have at least 9 bullets. And it becomes complex if you hit at least 14 bullets. Now, the bullets. Where do you get these so-called bullets? Well, there are 3 varieties of bullets: psychiatric, musculoskeletal, and constitutional. In psychiatric, you have 11 bullets. In multiple musculoskeletal, you have 2 bullets. And in constitutional, you have again 2 bullets. And let's see what are these so-called bullets. For example, in the psychiatric bullets are speech, thought process, association, delusions, mood affect, judgment or insight, orientation, memory, attention concentration, language, and fund of knowledge. See, there are 11 bullets there. In musculoskeletal variety are 2 bullets, and these are muscle strength and tone, gait and station. And finally, in constitution are 2 bullets. One of them is recording 3 vital signs, which can be blood pressure, pulse, respiration, temperature, blood pressure in supine and orthostatic position, and others. And general appearance is another separate bullet. So you see how it works. It's you have to document in the examination part of the note that you checked 1 bullet, or to have a problem-focused examination, 2 bullets, if at least 2 bullets, if you want to have an extended problem-focused examination, and at least 9 bullets if you want to have a detailed examination, and 14 bullets if you want to have a comprehensive examination. Now, finally, the history. History is measured also in complexity. Complexity, like medical decision. It can be problem-focused. It can be extended problem-focused, focus, and detailed, and finally, comprehensive. So you have, and this history is determined, this history's level is determined by 3 parts, who all must meet or exceed the criteria needed for a certain level. What does it mean? So the 3 parts are history of present illness, past family and social history, and finally review of systems. History of present illness is measured in elements. And for the first level, you need to have at least 1 element. For the second level, at least 1 element. For the third level, you need 4 elements. And the 4th level, you need again 4 elements. Now, what are these elements? Elements are a symptom for which you describe location, quality, intensity, duration, timing, context, modifying factors, and associated signs. So there are 9 of these elements. Practically, when you call a symptom sadness, you actually hit 2 elements. One is location, that means behavioral, and the second one is quality. So when you say sadness or anxiety or anger, you practically knocked out 2 elements at once. So it's very easy to reach a high level with these HPI elements. Now, the past family and social history has 3 elements: past medical, history, past family history, and social history. So practically you need just one issue in past medical, or one issue in past family history, and one issue in social history to score on this scale. Now the review of system is of 14 varieties, and is measured in 4 levels. 0 to 1 is 1 level. 1 point is 1 system is the 2nd level. 2 systems is the 3rd level, and all systems is the highest level of review of systems. So what does it mean? A review of system, in order to claim a history of complexity problem focused, you need to mention no review, no system. And a review of system means when you ask the patient questions to elicit problems in the different systems. Which are the systems? In psychiatry, we are dealing mostly with the psychiatric system, of course. And again, how do you distinguish between review of systems, psychiatric system, from the history of present illness? Well, these are items that are not referred to in the history of present illness. In the history of present illness, you describe the problem at hand, and then is like a checkup of the rest of the system. You ask additional questions. For example, if you are dealing with a depression, then you check the rest of the psychiatric system by asking about delusions and hallucinations. But this can also be in the examination part, as I showed you before. It's a little bit murky here, but this is in essence what a review of system means. Now, in what other systems can be useful? And again, you cannot pick up a system at random and plop it in there and consider that you satisfied your requirements. You have to choose something that makes sense for the context. And what are the other systems that make sense? Definitely, neurological system makes a lot of sense. So when you ask questions and document answers like no dizziness, no headaches, no tremors, no muscle stiffness, these are items that belong to the review of systems of neurological kind. Then you have the GI system that often happen, that is involved in psychiatry. Then you have the ENT, especially the eyes, vision, and you may have also some endocrinological review of system questions, and of course documented answers to satisfy the need for this item. So review of system is considered problem focused on when it's not mentioned at all, or it's one system mentioned. It's considered extended problem focused when it has at least one system mentioned. Is considered detailed when it has at least 2 of them, and it's considered a complete review of system when it's contains all the systems possible. Now, when you are talking about all the systems, it doesn't mean that you have to write a long list of questions that you ask to the patient. You can actually just write a simple question saying all other systems reviewed negative, and you satisfied the requirement of having reviewed all the systems in this item. So let's put it all together now and make a nice table here. The CPT codes 211, 212, 213, 214, and 215. And here we have medical decision, examination, and history. So let's see, what do we call? First of all, you have to remember this rule. 2 out of 3 of these elements, medical decision, examination, history, must meet or exceed the criteria for each of these individual CPT codes, as you see here. 211 has, surprise, no requirements of any kind. No documentation requirements of any kind. It doesn't mean that you can send a blank progress note to the insurance and ask for payment. You must put something in there to reflect what was that about, what is the service that you provided. But there are no rules. You put anything that you feel makes sense. And do not forget that 211 is one of the procedure codes that I recommended you to forget about, because 90% of the insurances do not pay anything for it. So it's more costly for you to document and to go through the fuss and getting nothing in return. 212. Now the medical decision must be straightforward, the examination must be problem focused, and the history must also be problem focused. Don't forget, it's 2 out of 3 elements must meet or exceed the criteria. But as you remember, the medical decision is really the more important one. That's why I put it here first, because this is what determines mostly the level of coding. You cannot have too much discrepancy between the level of the medical decision, either straightforward or low or moderate or high, and claim that you did the work. For example, you cannot have a straightforward medical decision and claim that you did the work for a 214 or 215 just because you can do it. You have time to do it. So this doesn't fly. So I would recommend that the medical decision should almost always be either at the level of the code that you are using or a little higher, or in rare situations a little lower, but not more than 1 step lower. So let's see, 213. Medical decision must be low. The examination must be extended problem focused, and history also extended problem focused. Now 214 has a moderate medical decision, complexity of medical decision. Examination must be detailed, and history must also be detailed. And finally 215, which has to have a medical decision of high complexity, and you must do a comprehensive examination and a comprehensive history to qualify for that code. So do not forget, you first look at the medical decision and you decide what code to choose. Never choose a code higher than your medical decision. Maybe one scale higher. For example, you can have a low complexity medical decision, but you feel that you needed to do a detailed examination, a detailed history, and therefore you claim 214. But it's not recommendable. Best is to always make sure that the medical decision is at or above the level of code that you want to claim. So this is the way it is done. But let me show you a simpler way to do it. Still okay in terms of billing, but it will save you a ton of time, and it also make time in your note or place in your note for documenting other issues that are important for clinical and also legal point of view. So let's see. Let's go back again to the CPT codes here, the same table. 1, 2, 1, 2, 2, 1, 3, 2, 1, 4, and 2, 1, 5. And we have medical decision, examination, and history. And let's do again a nice table. Okay, so let's see then. What I would say that it makes most sense in terms of completeness of the note is when you are dealing with an 1-1, again, you just put in there whatever you want. Something like patient came and went. Patient came, took a script and left, and so on. Or called the patient, spoke with him, arranged another visit. 2-1-1. As I told you before, not much reason to spend time with this. Now, if you want to claim a 212, a 99212, then what you would have to do is to make sure that your medical decision is a low complexity, it's a straightforward medical decision. That means you have a minor problem, one minor problem, and no medication. if you indeed have this situation when you have a straightforward medical decision, that means you are dealing with a minor problem and no medication or no medication, you just make sure that you have at least one bullet in your examination. And the history, I would put a dash in here, but I'm not putting a dash because I'm telling you don't put anything in there. Put what makes sense from clinical and legal point of view. So forget about what you learn about the history. Just concentrate, because the one bullet in the examination part is very easy to achieve. And making sure that your problem is minor and doesn't have any medication is very easy to document. And then you reserve the history for what makes sense from clinical and legal point of view. Now, if you have a 213 visit, you make sure, if you want to code a 99213, you make sure that the level of complexity of medical decision is low, is you documented. And what does it mean low? That you have either two minor problems, or you have one chronic stable problem, or there is a over-the-counter medication that the patient is using. So this is what you need to satisfy the medical decision as low. Now you go to the examination part and you make sure that you have 6 bullets in there. Again, very easy to achieve. And finally, the history of present history, the same. You put in here only what makes sense, clinical and legal point of view. Now, if you want to claim 99214, then you make sure that your decision is of moderate, medical decisions of moderate complexity. And what does it mean, moderate complexity? That means one chronic problem with exacerbation, or 2 chronic but stable problems. That's enough to qualify as moderate. Or you have a patient on medication, prescription medication, I would say, prescription medication, that needs active monitoring. So again, you have to document, even if you leave the dose the same, you have to document that you looked at the medication and decided to leave it the same. And finally, if you want to claim, and here in the examination part, you have to have 9 elements at least 9 elements. And here the same, clinical and legal issues should take center stage. Now, if you want to claim a 99215, then you have to make sure that you document that the medical decision is of high complexity. And what does it mean? You have one chronic or acute illness with severe exacerbation, the kind of exacerbation that puts the life in danger or a bodily function in danger. Or you have this is severe, and for example, suicidal ideation automatically qualifies as a complex medical decision. And here you have the alternative. That means even if there is no chronic condition or chronic or acute condition with severe exacerbation posing a life threat or a threat to a bodily function, if through the simple fact that you have a prescription medication but that needs constant monitoring, and you actively look at this medication and you ask yourself, should I continue, should I discontinue it, should I replace it? Just for the fact that you are asking these questions and you are talking about a medication that is complicated, that needs constant monitoring, then you already got to the decision, the medical decision of high complexity. And finally, the examination, if you want to claim a 215, you must make sure that you have 14 elements. And again, in clinical and legal, I would forget about everything that the CPT code is doing and put there what makes sense, clinical and legal. Now, you have to understand that when you do that, when you put in the history what makes sense clinically and legally, very often you meet that criteria for the certain level of coding anyway. But I just want you to focus mostly on clinical and legal issues when you use this part of the note. and make sure that you dedicate the rest of the itemized note to meeting the criteria for the CPT code. So this is a more straightforward and easier to remember way of dealing with the CPT codes. Check again this channel from time to time to see what new videos are posted. Thank you.